Okay, depending where you are in this country, good morning, good afternoon, good to see you all. Thanks for joining us. We want to talk through what the federal government has focused on over the last couple of months, perhaps last year, and where they're going to be going in the next year. And rooted in that is a really good assessment of where provinces are going and what they're thinking, what the pan-Canadian health environment is. So we will do that together with my colleagues. But first, a few quick notes. Wanted to flag, if you don't know who we are, we're Santis Health. We're a consultancy firm that focuses solely on healthcare. We do three primary things that we enjoy doing very well: strategy and policy development, communications and stakeholder engagement, as well as government relations and advocacy. And we do this with a rock star team, and some of those are here with us today. Patil is a consultant with us, works on our federal GR team. She'll walk through some of the political context. Marcel Saunier, an associate with us. Marcel's here with us and comes from a strong history of working for Health Canada and many other federal organizations over the wealth of his career. And then Ben King is with us as well too. He spent a good amount of time working on health data in the Ontario government and predominantly focuses on health data here with us here at Santis. A couple administrative items, sorry. First of all, in order to ask questions, highly encourage it. There's a Q&A button there. You can put in questions at any time. We will track them and try and answer them as we go, and we'll also have lots of time for questions at the end. But don't hold back on those questions. We're more than happy to think them through, and who knows, we might come up with a great idea right here, right now. The slides themselves will be recorded and emailed out afterwards. So if you do want to distribute, share, or watch again, just like we might Avatar when it comes out this year, feel free. And then the last thing, we'll send a survey around afterwards to make sure that we're focusing on the right things, that we're responding to things that you're curious about, and we can constantly improve the webinar offering to make sure that we're staying relevant and interesting to you. So with that, we want to start with a bit of a political context setting discussion. And for that, I'll flip it over to my colleague Patil.
So thanks, Peter. So on the current political climate, Trudeau's Liberals currently hold a minority in government. Since walking into the 2021 mandate, many of their platform priorities have been sidetracked by the pandemic. The priorities outlined in the Liberal NDP Supply and Confidence Agreement, the declaration of the Emergencies Act, and the subsequent inquiry. So the Prime Minister has recently confirmed that he will be staying on as leader of the party in the next elections, and has informed current MPs that if they want to hold nomination heading into the next election, that they should start financing and campaigning now. The Conservatives have recently elected Pierre Poilievre in a leadership race that sold record high numbers of memberships. Since becoming leader, he has not appeared in many press conferences as he reorients himself from finance critic to now leader of the official opposition. He has remained generally quiet on health policy and has rather focused his message on fiscal sustainability and the rising cost of living at the moment. The NDP is attempting to maintain their strength as an opposition party, but despite voicing opposition to Trudeau within the public and the media, it is overshadowed by the perception that Singh is working with Trudeau and has given up his power to vote in non-confidence of the government. So the current by-election taking place in the GTA is a little bit of like a canary in the coal mine. It's the first opportunity for Trudeau's Liberals to go head-to-head with Poilievre's Conservatives to test their new messaging with the public. A Conservative win would be presented as evidence that the CPC message and critique of the government is resonating with key ridings, especially in Ontario. And if the Liberals win, it'll be offered as evidence that Trudeau and the Liberals maintain some strength with a significant slice of the electorate. Since the election, polling consistently shows no substantial change in public sentiment towards the main parties. The Liberals and Conservatives are neck and neck since 2019, which is a bit of a challenge for both leaders as they look for favor amongst the electorate. So acting against the incumbent party is inflation, the rising interest rates, as well as Trudeau's extensive reign in office, and acting in favor of the CPC is the government's tenure, their focus on fiscal conservatism, and the fact that during economic downturn, populations tend to look for change in leadership. And the slight downtrend in PPC support can be attributed to the establishment of the new leader in the Conservative Party, looking to unite the support on the right. It is very important to note, however, that Liberals generally tend to outperform their polling, as seen in the last 3 elections. So despite winning the last 2 elections, they lost the popular vote. It's a testament to the strength of their vote efficiency. The Conservatives are favored in the provinces of Alberta, Saskatchewan, and Manitoba, and slightly ahead in the popular vote in Ontario. But the Liberals are very efficient in their votes in Ontario and are also very, very popular within the riding-rich provinces of Quebec and BC. They're also favored in Atlantic Canada. Also, in April 2024, the electoral districts will be redistributed as done decennially. It is too soon to tell how this will impact the next elections. However, we do know that many MPs are feeling uneasy, especially within the government. So top of mind for Canadians by a significant percentage is the economic downturn and rising cost of living. The Liberals, again, will have to be forced to readjust their priorities to suit public sentiment and angle policy towards addressing this recession. So for the health file, this may mean that government may put some of their big ticket priorities aside until seeming to address the recession. So as a refresher, just the next slide. As a refresher, in Q1 of 2022, the Liberals and NDP signed the Supply and Confidence Agreement. In exchange for the government's commitment on key NDP platform priorities, the NDP has agreed to vote with the government on all matters of confidence, including all government budgets. So if this agreement is maintained to full term, it would keep the current government in place until Q3 of 2025. On health-related priorities within the agreement, the government has shown most progress on dental care for low-income Canadians, launching a Canada Dental benefit that provides direct funding to Canadians. This shows significant federal interest in the delivery of healthcare and suggests that Pharmacare could be administered in the same way. It is still unclear what is sufficient to the NDP in terms of ongoing investments to address pressures on health systems, but it currently seems like it's a little bit of the NDP's response to the Liberals' refusal to commit to an increase in the CHT above the current funding formula. And finally, outside of the amendments to the criminal code, it will be very interesting to see what the feds will include to address their commitment to the Safe Long-Term Care Act.
Thanks, Patil. So let's dig into some of these things. And Marcel, I think we're going to hand it over to you to start talking about the CHT from the high level, and then we'll get into more detail and walk through some of the files that Patil just talked about.
Okay, thanks, Peter, and hi, everyone. So yeah, there's a few certainties in life, and one beyond just death and taxes. The third one is that there will be a periodic tussle between the federal government and the provinces on healthcare funding. And that's what we're going through right now. The provinces have been staking out a strong position in the last year or so that the federal government has been delinquent in funding healthcare adequately. So they are asking the government to increase Canada Health Transfer funding so that it goes up to 35% of what provinces are spending on healthcare. And that would be up from about 22%, so the provinces claim. On the federal side says, well, you know, there's not just the cash that we provide provinces, there's also the tax point that we transferred provinces some number of years ago. And when you put those two together, the federal level of support for provincial health spending is more like 33%. So actually not very far from the 35% that premiers have been asking for. So this debate is going to continue, and it came to a head earlier in November when the health ministers came together for a meeting, and we expect the conversation to continue in a robust way. Ultimately, the federal government, we think, is not going to be able to or want to concede to what the provinces are asking for in terms of getting to that level of investment the provinces are seeking, which amounts to about $28 billion a year more over the existing $40+ billion a year that's funded through the transfer. But they do have some plans to spend more money in healthcare, and that would be done through targeted vehicles. And so we expect provinces will quietly, you know, relent and take the new investments while trying to downplay any conditionality that the federal government says they have achieved or want to achieve in terms of making sure that the money gets spent where it was intended to be spent. So that's the way we think the conversation is going to unfold over the next little while. Perhaps in the next 6 months, we'll get a resolution. Moving on to mental health and home care. So the bilateral agreements that were signed 5 years ago in 2017 were really an important shift in how the government funds healthcare across Canada. The idea that there is the Canada Health Transfer that's there to fund ongoing healthcare spending is still, the dominant lever for federal funding for healthcare. But they introduced these bilateral agreements in 2017 with targeted spending of $11 billion over 10 years for mental health and home care. And the idea was that if you can ring fence that money and send it to the provinces to support these relatively underfunded areas of the healthcare system, mental health and home care, then you'll have a better chance of success in making sure that the money gets to the destination and getting the results for that investment. There was an amendment to these agreements in 2021 during the pandemic to include some new funding for long-term care. And now in this year, 22-23, these agreements are all up for renewal. There were 5-year agreements, the first tranche, and there's supposed to be another tranche of 5-year agreements put in place this year to flow the funding for the remaining 5 years of the 10-year commitment. But so far, only Quebec has signed an agreement, and it's not for the full 5 years, it's just for a 1-year extension. And our understanding is that other provinces are also seeking a 1-year extension to these agreements until such time as they have some certainty on how the federal government's going to be dealing with the CHT demands. And then a last point here, coming up in a few days, the Canadian Institute for Health Information is going to publish a report on common indicators that were developed to support this work, common indicators on home care and mental health. There are 12 of them this year for the first time. CIHI is reporting on all 12 indicators. So it'll be interesting to see what sorts of results come out here. And over the next few years, we expect to see more comprehensive reporting across all jurisdictions on all of these indicators. So moving on to the next slide, another big priority for the federal government, and one that was discussed at the November Health Ministers meeting, is health human resources. So there has been some investment by the federal government in this area and some action in the last year or so. There was a big stakeholder symposium earlier in 2022 involving many of the key stakeholders in the health workforce file. The government also appointed Leah Chapman as the federal chief nursing officer for Canada. That's a position that used to exist and was abolished about 10 years ago and now has been brought back into play. The government also recently created a coalition for action for health workers. And that involves many of the key associations across the country that represent health workers. There's been some budget 22 investments. And as I mentioned, this was a key issue that was discussed at the November 7th meeting of health ministers, and one where I think they expected there was going to be agreement, but the whole meeting fell apart once the premiers declared that there was not really going to be any agreement until the government was ready to talk about the CHT. And more generally in this area on health human resources, this is a really tough area for the federal government. They do have some levers, recognition of foreign qualified healthcare workers. They can use their convening power, their power to help create information and data to support analysis of health human resource needs. But really, it's the provinces that hold all the big levers in terms of education, training, health system organization, and funding of health providers. And so the provinces are all competing for a limited pool of health professionals, and it's difficult really to see how they will all come together with a pan-Canadian plan. think that's what the federal government is trying to use its funding to help to secure, but they're not quite there yet. Thank you. Over back to you, Peter.
I think we're going on to Ben from here, actually.
Yeah,
Go
thank
for
you,
Ben.
Marcelo. Thank you. So I'm going to talk for a couple minutes about data and data priorities federally. And I think had I presented this slide a year ago, this first slide would have been entirely focused on virtual care. In the last federal election, the Liberal government made a number of significant platform commitments around essentially doubling down on virtual care, increased funding, more investments in the provinces, longer term approaches. It really was sort of the priority a year ago, but it's very much in the sort of year since faded more into the background. And I think that's a reflection of sort of the emerging HHR crisis that the country is facing. And when it comes to virtual care, there are various ways in which virtual care can help to alleviate the HHR crisis, but I think people are becoming more alive to the reality that virtual care can also in some ways exacerbate HHR challenges and make things more difficult. So I think virtual care has sort of lost its preeminent position in these discussions, and instead the focus really has become on data as a key enabler to help address HHR challenges, because the sort of underlying issue with a lot of those challenges is we really don't have a good understanding of what the problem is. We don't really know how many providers are actually actively working. We have a good sense of how many are registered and able to work. We don't know how many are actually working. If they are working, we don't know how much they're working, where the very sort of basic core of HHR, we do not have that data. So when it comes to a federal, provincial, territorial approach to address the HHR challenge, a pan-Canadian health data approach has become seen as a really key enabler of that. And somewhat sort of opportunistically, there was a pan-Canadian health data expert advisory group that was formed shortly after the COVID-19 pandemic began to develop sort of a data response to that pandemic. But they sort of took their mandate and ran with it and put forward a very ambitious series of reports that articulated a vision for a national health data strategy. And that vision dovetailed quite nicely with discussions with the provinces around HHR. And it became quite clear that sort of this pan-Canadian health data vision would be a really remarkable and impactful enabler to help address or alleviate that HHR challenge. So for the federal government, they essentially put 2 and 2 together and said, we have this really, we think, important vision. We have this collective challenge to address. Let's work together to figure out what our health data approach is as part of our HHR strategy. The challenge really, though, is that the pan-Canadian Expert Advisory Group's report is very aspirational. It's very conceptual. I think it's been received quite well. I think a lot of the provinces in principle agree with it. Ontario, for example, recently released their Health Data Council's advisory report, and it sounds incredibly similar to the federal approach. So on the principles of what we want to achieve, I think there's a wide range of agreement. Where there is a greater challenge is in sort of more meaty discussion about, well, so what actually do we need to do to begin to put this in place? And then that gets into the much thornier questions of whether and how the federal government gets involved in a number of projects that provinces are already doing to better collect and use data in their local contexts. So this is a sort of key area of priority that's emerged in the last few months, and we very much expect this to be sort of the digital priority for federal and provincial discussions as part of those CHT discussions that Marcel outlined over the next year. Next slide, please, Peter. So that's the sort of big #1 priority, but there are a number of other interesting digital health activities underway federally that we'll be monitoring and that we think will be very important to reshaping the landscape. So the first of these is that for the last 15 years or so, there's been this sort of key structure around digital health federal leadership and the digital health federal role. And Canada Health Infoway and CIHI have really been I think the driving organizations federally for a lot of that work. But with the pandemic, Health Canada and the Public Health Agency of Canada ended up assuming a far greater role around virtual care funding and data strategy. And that raises a lot of questions about, as we emerge from the pandemic, how those expanded roles for those two organizations, how those align with the future role for Canada Health Infoway and Kai High. So we expect there to be a lot more clarity in the next 12 months around how those different organizations will be working together, and essentially what the federal approach to digital health governance and leadership is. So that's going to be a really interesting area for us to monitor. The second item of interest is, as everyone knows, has been in the last few years this explosion of data and analytics. There's sort of the universe of big data has a lot of opportunity, especially related to things like drug research and device approval. And that landscape, while impressive, has not in many ways sort of driven major changes in terms of how these products are actually approved from a regulatory perspective. And I don't mean that critically, it's a very complex area. But over the last couple of years, Health Canada and CADIF have been making, I think, quite impressive progress in trying to wrestle with these questions of how you use things like real-world evidence to drive decisions, as opposed to relying solely on things like clinical trials. CADIF right now is in the midst of a consultation on real-world evidence to try to develop their sort of long-term framework for how they would use real-world evidence to drive their decision-making. And if you think about for the sort of drug landscape and drug approvals in Canada for the next several years, these discussions, which I think will mature quite a bit in the next year, are really going to shape the regulatory landscape for probably the 2020s. And so I think we're at an inflection point in terms of government determining whether and how to accept different kinds of data and leverage the possibilities of big data. And then the last sort of opportunity space that I want to flag is that the federal government, through their Bill C-27, that's currently, I believe it's in second reading in the House of Commons right now, that legislation gives the federal government a number of new powers, assuming that it passes, to define regulations for private organizations around the sort of sharing of data with other organizations, as well as AI and machine learning in general. What those regulations will actually look like is unclear. They're not included in the proposed legislation. It just gives them this authority. But assuming that legislation will pass, which I think is likely, the federal government will have substantial authorities to define how AI and machine learning work in Canada, to define how those are applied, if they're applied in a healthcare setting. And so this will create, I think, a really interesting policy space in the next few years to determine whether and how the federal government wants to sort of manage and address some of the more complex questions around data usage and AI.
Thanks for that, Ben.
Back to you, Peter.
We'll flip over and start talking about Pharmacare and the CDA, and I have the benefit of seeing who is all listening to this webinar, so I look forward to saying some things and then maybe getting an email and being told whether I'm right or wrong afterwards. But I'm also conscious that we have Marcel with us, who, for those that remember the before times, pre-2020, there was a lot of activity on Pharmacare from the federal government. First, you had a standing committee of health in the Trudeau government's majority mandate, look at what Pharmacare could be, and that's where the parliamentary budget officer did a little bit of an assessment in terms of how much it could cost. And then Marcel, in one of his previous lives, was the executive director of the secretariat that was looking into federal Pharmacare program. That was the Eric Hoskins panel. And where we sit today is the NDP finagling a deal out of the federal government that they would pass legislation by the end of 2023. So where do we sit right now, and what does this mean? The federal government has to be undergoing their own reflection in terms of what that policy could be. We have all talked about Pharmacare in a million different ways over the last 5 or 6 or 7 years, long before that, prior to this mandate, but we'll focus on the Trudeau mandate in its own right. And the federal government has not made a judgment call or made a policy decision in terms of what is the model of Pharmacare that they want to implement, that they believe in, that they feel that the federal government has a role in. And there also needs to be a reflection around what in fact the federal government can do. So a couple of questions that we would frame up, and we've had this conversation with clients to kind of tease out from their perspective where they see themselves sit in this world. And right now we have to reflect that provincial governments, provincial drug plans, they're all starting from a different place. They all have different models. They all have different fiscal capacity. They all have different a number of drugs that are covered. Some of them have different amounts of copays, whether you go to Atlantic Canada or other parts of the country. And the federal government needs to reflect on what is the standard that they want to set and how will they respect provincial jurisdiction, and then how do they also respect where provinces are currently starting from. There are many different visions for how you can achieve national pharmacare, and we'll talk about in the next slide a couple different debating visions that the federal government has to come to ground on, and how involved the federal government would want to be on this sort of policy at the far end versus on the narrow scope. How much money would they want to give to in order to support provincial governments doing something they would like with drug coverage? So from an implementation standpoint, in terms of how the federal government could implement it once they figure out these policy questions, there's a number of different modes they could implement it. They could be something as simple as how they did dental care, which was a supply bill, money. It could be something a little bit more prescriptive, a standalone piece of legislation. The NDP did their own private members bill last year, 2 years ago, on a very robust single payer system that was very detailed in what provinces needed to do get funding. Basically, it sounds like a Canada Health Act esque piece of legislation for pharmacare. But all of this is to say there's a wide range of things they could do, and the government would need to figure out, perhaps, do they incentivize enforcement? Do they enforce enforcement? How do they get to the end goal of what they've established in the policy development process? And then they also need to figure out how do they work on this with provinces one by one or as a collective. And more than likely it would be a one by one. There are some provinces that would be interested in this more than others, but there are a lot of different competing priorities. So the federal government, they have to meet the agreement that they landed with the NDP. They have until the end of 2023. They've identified that there are gaps in coverage. They've had several consultation papers over the year that gives you a sense of where their headspace is going. I am not convinced that they've sent out strong messages that they're looking to completely upend the drug coverage system overall and institute a very a universal single payer system federally. I just haven't seen that, but at the same time, they haven't made that pronouncement. The other thing they have started working on, though, is what is the foundational work that they need to do in order to support pharmacare? What are those institutions? What is the data? And this kind of goes to a little bit of what Ben was talking about and some of the lessons learned that we're going to hear from on home and home care and mental health that Marcel spoke through. But what are the foundational pieces they need, the federal government needs, for the federal government and provincial governments to make more informed policy choices? So that's everything from the Canada Drug Agency Transition Office, which we'll talk about next, how to collect data. CADTH's doing a lot of their own work right now on real world evidence and the others. There's a lot of stuff happening in this space. There was a consultation on a national formulary that was spearheaded on a pan-Canadian panel, some of whom are listening to this call right now, that was run through CADTH. There's a question around how do provinces participate and to what level is the PCPA supported or not. It's a beast of the provinces. The federal government's an observer on it. And then there's been a question of bulk purchasing, something that's been stated several times as a potential benefit to provinces coming out of COVID in terms of how it worked purchasing some medically necessary devices and vaccines through COVID. Is there a lesson to be learned there? These are all questions. The NDP wants to hold the government to account, get that act passed, and I would imagine if you talk to the NDP, they would say this is a starting place to go somewhere greater. I don't think anybody expects some big system to come in place right away, but it's a starting place. On the provinces, they've been quite clear in terms of what they're focused on. And we have a slide that runs through some of the provincial priorities. I would say this is not the top issue provincial governments are focused on, and premiers put out a very clear statement that participation should be voluntary. It should be focused on removing cost barriers for patients, and that provinces and territories must retain the responsibility that they inherently have over the delivery of public drugs. Non-governmental stakeholders there's a big range of beliefs. On one hand, you have the fill the gap model, which is predominantly where I think most provinces sit. Who is not having coverage, and how do we make sure that they get coverage? I don't think anybody's disagreeing that everybody in this country should have a sustainable access to drug coverage. But then there's a little bit of a nuance in terms of, well, who is delivering it? Is it single payer? Is it not? There's definitely a strong advocacy group around that. And then there's also those who are actively engaged in the system that don't want to see major disturbances as they're trying to continue to provide this coverage year over year. So it's not it is a thorny stakeholder environment that the government will have to navigate. How about we just leave it at that? I'm really curious to see how this lands with some of the people on the call right now. But we've been thinking through what's going to happen with the CDA. What are they working on? I suspect we'll see something more public on them in the next couple of months. Their 2-year existence of the transition office is up in April. And I think we can get a sense of some of the things the CDA is probably thinking about and looking to work on. And I don't think this will come as a surprise to anybody who has read the Pan-Canadian Health Organization report that PG4A and Danielle Martin produced back in, what was that, Marcel, 2018, 2017, 2018? But a lot of these themes are there. It's also been part of mandate letters as well, too. So when we talk about data coordination infrastructure, Minister Duclos has been talking about that in context of federal funding to provinces. A promotion of appropriate prescribing has been something that the government has had as part of the three-prong approach to drug coverage, to drug reform since 2015. There's an evolving discussion around how you provide jurisdictional support for product listing agreements, especially for some provinces that don't have as robust of a procedure as, say, HTA procedure as, say, Ontario or Quebec or BC has, as well as pharmaceutical system coordination overall. So how are we making sure that things go from A to Z and that patients are getting access to the drug in a timely manner at the end of the day? I don't think those themes are surprising. I think they're fairly safe for us to expect it to be there. And then I think we'll look forward to seeing what the CDA could permanently do. There is some discussion amongst us nerds here at Santis around where this thing will be housed. There could be a standalone agency, there could be transforming CADIF in some way, or there could be transforming the PCPA into a new agency. I don't think the last one is on the table at all. I think that's a beast of the provinces. So we can probably set that aside. And I think there's an ongoing discussion on how they reorg their existing agencies that are supporting this work to bolster it up, and whether or not they need to have a distinct federal Canada Drug Agency in addition to everything that exists, or there needs to be some reorganization and some additional responsibilities put in underneath an agency is probably something that's being constructed. But we will see, and we are happy to speculate about this, but I think this is where the tea leaves are going a little bit. We'll talk about rare drugs for a second, and I'm seeing questions come in. We will tackle the questions. We have lots of time, and we look forward to doing those. On rare drugs, this has been a commitment that the federal government has had since 2019. Funding was set to flow this year, 22-23, $500 million. We haven't seen anything on that. I think it's a fair question that stakeholders ourselves would like to see where the government is currently at. There was, to the government's credit, they focused on doing these consultations through COVID when Health Canada was stretched for capacity. So we have to give credit there, but we also need to think about, well, what is this framework turning into, and what are they going to invest the dollars in that they have set aside? So there's a discussion that Health Canada has done, oh goodness, 2 rounds of public consultation, and then lots of one-on-one with stakeholders as well too. 3 buckets of work that they've been focusing on. So one, drug coverage. How do they make sure that the formulary is getting drugs on there that have appropriate efficacy, but also that patients need, filling gaps that exist in Canada? What sort of disease states actually exist in Canada, and what drug categories are not currently being covered that ought to be covered, and what are the problems that exist in the drug approval system that rare drugs are uniquely challenged with, because they have different data inputs and different outputs in terms of patient benefit than, say, a blockbuster drug might have. Those are questions they need to tease through, and the federal government also needs to tease through what can they do versus what guidance can they be doing to support provinces in this. On governance, this is figuring out how they make the decisions that they should be making, that there's national consistency across the country. I think a big problem, especially for those patient groups on the line right now that they fight with every day, is that you might have a drug available in British Columbia that's not available in Ontario, and people are moving from one jurisdiction in Canada to another to get access to a drug. That just doesn't sound like something we would want to have happen in this country. And we do have happen in this country, and we need to solve that. And there's a lot of consideration work that has been done. One of our clients, Takeda, has done a lot of work on this in terms of figuring out what works well in other jurisdictions and what ideas can we adapt in Canada. I know many other stakeholders on this call likely have thought about that too, but what can we learn from other jurisdictions that might be able to be thoughtfully implemented in Canada's federated country? It's a little bit unique here because of our governance structure. And then the big piece is, how do we gather evidence? How do we collect that evidence? How do you make sure it's interoperable between jurisdictions? And how do you make sure you can package that evidence up for policymakers so they can make informed decision? I think that is a fundamental challenge that Ben was highlighting amongst his section. And I think, Marcel, I think the same can be true for home and community care as well. This is a problem that we will have until we solve it. So I'm going to pause there. This is, and I'll ask Marcel, Patil, and Ben to chime in here as you see fit. We didn't talk through all of these things, but these are the things on the federal government's to-do list. And these are the things that federal government needs to put capacity to. And to Patil's excellent lead-in, they have to do that amongst competing priorities, like getting ready for an election, doing a budget, dealing with inflation, dealing with whatever might come up in the course of government business, natural disasters, and the rest. And this is just health. So we talked about Pharmacare, where PMPRB is an ongoing file that has been dragging out for a good 5 years. And I know the consultation for the latest guidelines closed yesterday. And I think we're already hearing that there's likely going to be a little bit longer needed to reflect on those guidelines. There's the health data conversation will continue going, HHR, and there's a lot of work on life sciences coming out of the pandemic to make sure that we have a sustainable supply of drugs and therapies here in Canada. But I don't know, Marcel and Ben, is there anything here that jumps out that we didn't talk about that you feel we should? And I'm thinking we should mention dental care very quickly. But aside from that, I want to ask you if there's anything here you would like to highlight.
No, I think from my perspective, we've covered a lot of these. Didn't mention the mental health transfer and national standards piece in my piece on the bilateral agreements. That is clearly a very important file for the mental health sector, and how we transition from these bilateral health agreements and the work that was being done on mental health to a new mental health transfer arrangement, and presumably with conditions and national standards. That's going to be another leap, I think. But yeah, clearly a lot of priority files on the table federally. I actually think that there's some good, convergence with what the provinces have as priorities. That the big issue is like who gets the say on how things get done, I think, is what it comes down to, and whether there are conditions attached to what the federal government wants to do, and what kinds of conditions.
Thanks, Marcel. Oh, sorry, go ahead, Ben.
Yeah, so one other thing I'll reference. So I said in my portion that virtual care had fallen down the radar somewhat. That doesn't mean it's fallen off the radar. And I think the kind of two really interesting lingering questions around virtual care. One is the federal government in their platform commitment did indicate an interest or an intent to fund send a lot of money to the provinces for virtual care, and that may sort of come back up as part of FPT discussions, or maybe being the next election. I think there is sort of this lingering large investment that they have said they would do. It didn't occur in the last budget. That doesn't mean it's gone. So we will certainly be monitoring any signs that is coming back. The second on virtual care is, and we talk a lot in sort of the HHR strategy in general about the possibility of pan-Canadian licensure, or at least cross-provincial licensure, and virtual care obviously is something that makes that question more salient. The idea that if I'm on one side of a border, I can do a virtual visit by doctor, but not on the other side of a border, 10 feet away. So I think discussions about licensure across country will also be discussions about the future of virtual care. And that's important across the country, but it's especially important in the more remote regions like the territories, where there was in the pandemic very good access to virtual care enabled by a number of temporary measures put in place to enable sort of national approaches to providing care across borders. And long-term, it feels like an obvious sort of enabler of long-term improved healthcare in the country's more remote regions. So that will be a really important area of policy development in the next year or two as part of the sort of broader HHR discussion.
Thanks for that, Ben. The only other thing I'd say in terms of the wrap up of federal policy files is just to watch dental care. And Patil alluded to it when she highlighted it earlier in this webinar. But the federal government, I believe they've gone out to an RFP for private payers to figure out how they might be able to implement federally led dental care program. Really interesting to see how this plays out, especially the feds are getting directly involved in providing benefit programs to Canadians and how they might learn some lessons on this as it relates to Pharmacare. And then the second piece tied to that with Pharmacare, if you haven't read through the PEI agreement that the feds signed with them around Pharmacare implementation, the MOU that they signed with PEI has a lot of rich questions that might help you get a sense of where the federal government might be going on that file. So those were the only two things I wanted to throw in there. This is now contrasted to provincial issues. And I should say on the slide that you saw before and on the slide that you're seeing now, if you're a client of ours, we have detailed information on every single one of these, whether it's in a form of a memo or somebody who's a subject matter expert that can talk it through. So offer it there for our clients. If you want to follow up and talk about any individual one of these, we are more than happy to do so. Public health, we haven't talked about much on this webinar, and it's something that we need to keep talking about because we just went through a massive pandemic, and time and time again, we go through these crises, and public health is top of mind as we're trying to figure it out, but it doesn't seem to keep on the radar once we all decide to move on our lives and deal with it. But public health renewal, reform, and investment is an incredibly important issue, especially as we look at how different jurisdictions across this country deliver public health, which is, it's all very different. We've talked about HHR. Surgical backlogs is a piece. The federal government actually promised $6 billion. They only gave $2 billion for it so far, I believe. As well as continuing issues with supply chains. But these are the things that the provincial governments are going to be focusing on and talking to the federal government about. And I think we wanted to call out between the last slide and this side is that this slide is the very real, this is what's impacting the healthcare sector. And the slide before are the things that the federal government wants to talk about that they may or may not have the ability to influence with funding, without funding, but it's a little bit more of a gray area discussion. They have to decide if they want to incentivize or regulate or do something with it. This is the meat of the matter, what the provincial governments are responding to every single day. And this is what will feed into conversations federally as time goes on, because the federal government will inevitably be responding to issues that exist provincially. Dental care being a priority of the NDP was a little bit out of the norm. It's very clearly not on this list. They have their own stakeholder community they have to respond to, but at the end of the day, the provincial territorial issues are the meaty ones that they need to respond to. I know Ben, Patil, Marcel, is there anything you want to chime in here before we switch to questions? Great. So why don't we do a quick key takeaways, and there's lots of great questions in there that we're going to tackle now. So I think I just highlighted it, but sometimes the federal focus can be misaligned with provincial priorities. That's something that we've seen before. There are sometimes reasons for that, but the reality is that those provincial pressure points will impact what the federal government needs to do, outside of the fact that the federal government's maintaining their government, and they need to do so with the support of the NDP, and that might influence what the federal government does. I think the last federal government, safe to say it wasn't a healthcare budget. I think, Patil, we ran the numbers and we looked at the Liberal Party 2021 set of election funding commitments for the fiscal year we're in now and what was in the budget, and there was about a $8.5 billion gap of promises versus what actually made it into the budget, and that's not even including Pharmacare and dental care. So I think there's some very fair questions around, you make a lot of promises to healthcare, but where is the follow through, and how are we actually moving forward on a couple key initiatives that you've made promises to? The government does run the risk of over-promising and under-delivering, and that's something that I think is being consistent with healthcare, even up to the time that I was there. It's a tough one as well, because you're dependent on provincial territorial collaboration. If you don't get that, you still are making a commitment and not being able to follow through with it. The last thing we would say is provincial and federal governments, they'll all need to shore up their support for healthcare. The public is not really concerned with the debate on what level of government spends our taxpayer dollars on healthcare. I think it's always a bit of a lost argument, the CHT piece between the federal and provincial governments. It's a broken record, happens all the time, and the public is never really engaged in it. But the governments will need to respond in kind, because we're recovering from a pandemic. We have some big issues that we've talked about today, and the issues are just going to keep compounding as our aging population continues to get older and pushes our healthcare system to a tipping point. It is a very, very, very real challenge that everybody on this call is dealing with. And our job is collectively is to make sure governments are zeroed in and focused on these challenges so that we can address them before they become massive issues. And that is what we like to do here at Santis, and that's why we like to work with all of you to get that done. So, questions? Patil, do you want to run through, or would you like me to? How do you want to do this?
Maybe we can group some together.
Well, there was actually a couple here that might, we could actually just send you, Marcel, off the top. One from Glenn around what is the potential to set up a blue ribbon panel to address or settle the federal fiscal dynamics, how much is transferred to the PTs. I think the question is this going to be a forever broken record, or is there a way to resolve this? And do we have a gut instinct on that? If you have your little crystal ball hanging out there below the camera.
Yeah, I think it's an interesting idea whether there needs to be some kind of a process here to try and resettle this issue again. There have been times when the issue has been settled, 1977 with established programs financing. In the late 90s, the agreement on the social union framework, which was broader than healthcare, but involved, all the provinces agreeing on what the rules of the road would be in terms of new national programs and funding. And so I think we need something like that to happen to sort of clear the air a little bit on not only funding, but how the federal government and the provinces should be working together for the benefit of Canadians in healthcare and possibly in other areas of social policy. There's just been too much happening in the last 20 years where we're kind of in a bit of a logjam. And we see, I think, provincial governments in some parts of the country even, wanting to have even greater autonomy, and we have the federal government wanting to get even more directive on how health spending is used. So something has to give there, and I think getting some sober second thought and some insights from experts and people that could spend some time kind of independently at arm's length looking at this and looking at the funding arrangements and the FPT dynamics would actually be quite helpful. I mean, it would delay resolving this by a couple of years possibly, but it might actually be a great investment for the longer term.
Thanks, Marcel. I might hit off another question around the national standards for long-term care. Thanks for the person that asked that. We've been watching the standards piece. It's been relatively quiet. I think we're expecting the standards piece to be released sometime at the end of January. And what is particularly unclear is what the government will do with those standards. How will they, are they just guidelines that will be out into the world? Will they be enforced? Will they be incentivized enforcement? What do we do with these guidelines once these standards once they're out there? So I would say stay tuned. I think we're targeting internally to see something hopefully in the new year, but conscious that could be a moving target because I think we anticipated something this fall and they moved there as well too. Ben, there's a question here on Bill C-27, and this might be one that you need to look into a little bit more. So if I'm putting you on the spot, we can always just follow up with the person who asked it. But do you know how C-27 might impact or affect confidentiality, sharing of medical information, which is already limited as there is a circle of care as is? Is that something you're prepared to tackle now, or is that something we need to follow up on later?
Yeah, so I can tackle it now with the proviso that I'm not a lawyer, so don't take my advice as legal advice. But I think so. Bill C-27 basic structure is that it's meant to be enabling on individuals. The premise is that individuals should have control of their data if that data is held by private sector, and that includes the ability to know what data an organization has related to you, to be able to access and correct that data, and to be able to say, I want my data to move from this location to that location. I think the key driver for Bill C-27 really is social media. I think a lot of this is driven by the idea that the Facebooks of the world are sort of misusing individual data, and people should have more power to sort of use their data, but the legislation is sufficiently open that it really can be applied to any sector. And so it's sort of to be determined whether and to what extent the federal government chooses to apply that to the health setting. The interesting sort of convergence there is the Competition Bureau of Canada just finished a series of market study reports on digital health. And one of their first and largest recommendations was the idea of preventing data blocking in the healthcare system by vendors and enabling individuals to ensure that their data moves from one location to another. So even if that wasn't the intention of Bill C-27, C-27 would become the vehicle to enable that kind of reform. So I think the legislation will probably pass in some form. And I think the sort of inflection point or question mark for the next 1 to 2 years is whether and in what instances that gets applied to healthcare.
Thanks, Ben. I might tackle the next one and ask Ben and Marcel and Patil to chime in if you have any thoughts, but the question around why Ontario has limited the fees that physicians can charge for virtual care. The person noted that it seems counterintuitive for HHR issues and bad timing. I can comment on this from my time working for the Ontario Minister of Health for a couple of years. I was on the government side for 2 negotiations with the OMA, and one of my colleagues, Patrick Nelson here, he was actually at the OMA for quite some time and experienced it from the other end of the table. And we have a strong group of folks working in Ontario, including Stephanie Gower and Chris Deere, who are very up to speed on this. But from stepping back and going into the government and how they make these reflections on what they should pay for fees, the past 10, 15 years, there's been a lot of reflections in terms of what the OHIP fee code has been historically and how technology has changed in order to allow that care to be delivered in a much more efficient manner than it once before. So back in 2013, when I was doing rounds of fee changes, we were looking at procedures that once took an hour and now only took 10 minutes. So why are you compensating individuals for an hour worth of time when you can do it in 10 minutes? And that's just a logical thing that you need to do in order to constrain the growth of the OHIP budget. You pay for people to work that needs to get done, and you make sure it's reasonable and fair for the time given and the materials provided. I would imagine that there's a reflection on the amount of virtual care options that are being provided and how much faster, efficient, or how much easy accessible it is, and a reflection on what individuals actually need to be compensated to do those. I'm hesitant to wade into the specifics of it because I don't know it. I don't know it in and out as much as my colleagues do, who are an Ontario team and will happily tackle this in their next webinar. But I can speak from personal experience that those reflections in government as to what the justification is for those change, it is done, and it's often a contentious one when you actually do need to roll it out. And I do think we need to realistically look at how virtual care makes it easier to access care, but also in some cases it makes the care faster to deliver as well too. And that governments are very conscious that as we move to a virtual care environment, that they could see exponential growth to their budgets or to their expenditures because people are accessing care more and more. I think COVID did a good thing that it enabled more virtual care options to come into place, because I think government, and Ben, I'll get you to comment on this, I think government was holding back on virtual care options before they were forced to have to, because I think they were worried about the cost implication on the government for doing so. And that will always be a tension point for government and how they deliberate on what these compensation fee codes are. So I don't know, Ben, if you take disagreement or have any other thoughts on that.
Yeah, so I think if you see a doctor as kind of a sort of ongoing physician relationship, if you're part of a rostered practice, your fee codes aren't changing. You have a sort of permanent virtual care compensation framework in place that pays for virtual care at parity. I think that the key driver here was concern about too many physicians adopting virtual only practices. Looking back a number of years, there was a period when the majority of virtual care in Ontario, when it was still quite neat, the most common use case of virtual care in Ontario was clinics that specialized solely in cannabis prescription. That's not, I don't think, the case anymore, but that was sort of 5-6 years ago, the big use case for virtual care. And I think Ontario and the OMA, this is a negotiated agreement, both have this idea that sort of long-standing continuous physician-patient relationship is really important, and virtual-only practices are problematic. The other interesting part here is around timing. Obviously, the timing is not good given the crisis happening today, but this agreement was negotiated last February. This specific set of clauses was probably negotiated for February because they probably weren't that contentious. So they planned this quite some time ago, probably not anticipating that they would come into place right in the middle of this crisis of access that's very front and center in everyone's minds. So I don't think the timing was intended. I don't think they really had a great sense necessarily of the different kinds of clinics that this would negatively impact. But there's this sort of longstanding position that sort of virtual only practices can lead to lesser care, or to Peter's point, should have lower costs and thus be sustainable with lower fees. So I think those are sort of the key drivers of this one.
Thanks for that, Ben. One that Marcel and team all might want to tackle. We have a question around HHR and the federal government focusing on, the main healthcare professionals that often are part of these conversations, physicians, nurses, and we have some pretty incredible representation for those groups in Ottawa, but there's also a lot of other groups. And if the federal government will recognize the need for unregulated positions as part of the healthcare sector and as part of this reflection on HHR, specifically PSWs and healthcare aides. Before I turn over to Marcel for you to comment, maybe I might also note that this federal government did put commitments in place in the last platform for PSWs, training for PSWs, wages. I don't think I've seen that implemented this year, but it is one of the commitments we listed on our slide that the federal government did make, and I think there will be a need to see the federal government follow up on that. But it dovetails nicely now into their HHR initiatives that I know that they're saying the initial group is just a starting point. They're looking at chatting with more people, but I don't know, Marcel, if you have any thoughts there.
Yeah, I think that it's not nurses and doctors to the exclusion of all others. Surely there is a bit of a sharper edge there, and some of the conversations we've been hearing about on physician licensure and nursing shortages, I think, are front and center. But as you said, Peter, there's been already investment through the pandemic and some hints at some further investments for unregulated workers, PSWs in particular. I think, it'd be interesting to see what comes out in the long-term care space and the legislation the federal government is going to be tabling, how the work on home care evolves as these agreements with the provinces get renewed. And I think one of the things the federal government can do really well on the HHR file is to support through funding, the development of standards and curriculum and, other kind of ancillary supports for the health providers across the country. And so I expect to see more of that happening, as clearly we have a crisis that kind of spans across the system now, including both regulated and unregulated professionals. So I expect that there will be some openness and some supports provided for unregulated professions.
Thanks, Marcel. We have time for one more question. I'll ask it. And before I do, I want to thank Ben, thank Patil, thank Marcel, and thank all of you for attending and being part of this healthcare journey with us here at Santis. We look forward to doing this more with you, and we all hope you have an amazing holiday and time to recover and relax after a absolutely bonkers September, October, and November cycle that we always experience federally. So the last rapid fire question, and we'll go Patil, then we'll go Ben, then we'll go Marcel. Do you think that the economic slowdown is going to impact provincial, federal governments? Do we have a sense of if fiscal restraint is coming up? Are we worried about the upcoming recession? And each of you can take a crack at that in 5 seconds, and we'll leave it there. So I don't know, Patil, if you have thoughts there.
So with the finite amount of resources, I tend to think that there will be a little bit of restraint on priorities that haven't seen any funding yet. We don't see any, I don't expect there to be any huge big ticket items that haven't already been committed to yet.
Ben?
I think there will be some impact, but less than expected. And I think the big driver is as long as it's an HHR challenge and you can't hire nurses, that means there's money that you aren't able to spend. So every hospital that has a nursing shortage also has some money left over. So until the HHR crisis gets much better, I think that the impacts won't be that direct.
All right, Marcel, you're a pinch hitter. Take us home.
I think it all depends on how deep this recession that is coming at us is going to be. And if we see much more significant impact in terms of jobs and tax revenues and increases in interest rates that are driving debt payments higher and crowding out other investments, I think we'll see more restraint than otherwise. But I think that question remains to be seen.
And that's an hour on the nose. Thank you, everybody, for participating. Thanks to my team here. We love doing these, and we look forward to chatting with you again soon. Happy holidays to everybody.